All right, everybody. My name is Binyam Molina, and I'm a clinical assistant professor here at UNC in the DPET division. I'm going to be talking to you guys about chronic lymphocytic leukemia. I hope everyone is staying safe and healthy during this outbreak. And remember that, especially for younger and healthy people, the goal is to not be able to contract it. So we will protect those who are most vulnerable, and that includes a lot of the immunosuppressed and immunocompromised patients that you've been learning about in the HEMONC elective, CLL patients being one of them. So we're actually going to start with this patient case. So AD is a 78-year-old female with hypertension and osteoporosis who presents with progressive fatigue and recurring bacterial infections. She reports poor nutritional status, and you can see her labs there. If you guys are not familiar with that diagram, basically her white blood cell count is 91, hemoglobin 10, hematocrit 30, and platelets are 288. Family history, so you can see maternal grandmother died due to a blood disorder. Blood smear reveals smudge cells. We'll talk about what that means. And then cytogenetic studies reveal 11q deletion. So CLL is a clonal expansion of small lymphocytes. It accumulates in the marrow, lymph nodes, blood, and the spleen, liver, and other organs. And this is important when we're talking about staging as well. One thing, big picture, that I'll talk about it is, it is a B-cell neoplasm, as mentioned. It is a type of lymphoma. It is called a leukemia because of the number of blood cells that are actually found, or the number of malignant cells found in the circulation rather than in the lymph nodes. But you can have a situation where if the circulating lymphocytes are less than 5, then we actually will refer to the same disease entity as SLL, which is small lymphocytic lymphoma. And as I'll discuss in the next few slides, actually CLL goes on to progress into a lymphoma, a high-grade lymphoma, if left untreated. As far as epidemiology, so you can see 20,000 new cases every year, 4,600 deaths per year. This is considered the most common adult leukemia in the United States. Median age is 72, so it is really an older, it affects older people, and so that is really important when we're thinking about the chemotherapy regimens and treatment options that we have, and how our patients will be able to tolerate it, especially those who have, multiple comorbidities. And it's more common in men than women. As far as etiology, there's been a lot of studies done in trying to understand the biology of this disease. One thing we know, and we've known for a while, is the role of BCL-2 on the pathogenesis of CLL. And I used to show the slide, it's the same slide for the past 8 years, and talking about CLL, and I used to always say if we could block BCL2, that would be kind of like the magic bullet. And actually in 2015, we had a BCL2 inhibitor approved, which we'll discuss. So it's been very, very exciting, and has changed the trajectory of CLL treatment, especially CLL treatment in patients who have high-risk mutations. So when we look at this, what risk factors does AD have for CLL? There's not much known as far as risk factors other than family history. So there is a strong correlation there. So you can see that this patient, just like a lot of our patients that we see in the clinic, they may not know if their parents or grandparents had CLL, but they usually say that there was some blood disorder, some blood problem that their grandparents may have had, or parents may have had, and that usually can give you a clue as far as the family history for CLL. So pathophysiology, again, this is a B lymphocyte neoplasm. Usually these B cells, they would have the expected CD20 marker, but they can also have a CD5 marker, which is present in lymph nodes. These CD5 positive lymphocytes accumulate, like I said, in the lymph nodes in the spleen. One thing I'll note here is that CLL is not a disease. It's not a proliferative problem that we have with CLL. Meaning, with a lot of malignancies, you have cells that are replicating, and there's a proliferative process going on, and that's really the driver. Here, it's really loss of apoptosis. So these cells that are there that are old and really should be discarded through normal biological pathways, that apoptotic process is not happening. And so these cells sort of hang around for a long time and can, clog up like I said, the spleen, liver, the lymph nodes, so on and so forth. So that's really the problem, is like this loss of apoptosis. And typically, if you're reading a report and you see something where there's a mention about smudge cells, when a blood sample is taken under a microscope and essentially when it's put on the film, a lot of these cells that are older, they end up bursting because they are really unstable, and that creates a smudge, and that's very characteristic of CLL, although obviously we still have to do the proper diagnostic tests to be able to determine that this patient has CLL. As I mentioned, risk factor, being family history. How do patients present? Patients present, so you could probably predict a lot of these things. So as far as lymphadenopathy, splenomegaly, that makes sense from what I just described. Chronic infections, you have these lymphocytes that are present, but they're not, over time, the B cells can stop functioning properly. So you may have improper functioning of the B cells. Obviously, the role of B cells is to make and produce antibodies, and if that's not happening, you can have chronic infections. Bleeding is also possible. Mainly over time, you can have these cells these lymphocytes, these leukemic cells that infiltrate the bone marrow, and then you can have crowding out of the bone marrow. Then normal cell processes are compromised, and so you can have anemia and thrombocytopenia. And so you can have fatigue and bleeding at much higher grades or later stages of the disease, and we'll talk more about that with staging. As far as laboratory findings, hyperleukocytosis, so high white blood cell count, specifically, we'll need to do a differential. So you can't just get a CBC or complete blood count and have all the information that you need. So you really do need to do a differential to see what the absolute lymphocyte count is. And oftentimes you'll see, when you're monitoring patients, you'll see that lymphocyte doubling time, shrinking over time, meaning the lymphocyte counts are rising. And even if patients are, not symptomatic, that's one way that we track how kind of how the disease is expanding over time, and it can be a marker for higher grade diseases later on if treatment's not started in time when we're seeing the lymphocyte count increasing. As I mentioned, anemia, thrombocytopenia, hypogammaglobulinemia, of course, from B cell dysfunction. You can also get T cell immunodeficiency just because of the kind of relationship that exists between B and T cells. And neutropenia is also possible. Again, this all has to do with bone marrow cellular mechanisms that are compromised from infiltration of leukemic cells. So I know I referenced staging. Go ahead and just focus on this RISE system, RISE staging system. There's also this Binet staging system, but I will, want you guys to understand the RISE staging system. It is fairly straightforward. So stage 0 basically is lymphocytosis without any other symptoms. So patients are typically asymptomatic. This is what I was referring to a few slides ago. Basically, patients will be tracked, their lymphocyte count will be tracked, when they're in stage 0, and, after a certain point, even if they're not symptomatic. You can sort of predict if they're going to go down the stages 1, 2, 3, 4, based on how quickly their lymphocyte count is doubling. So that is, we do monitor these patients closely. We typically don't treat them though, and we'll talk about when we treat versus not treat in just a moment. As far as stage 1, is lymphocytosis with a large lymph node. So these are patients who have lymphadenopathy. This RISE staging system can be, it was developed in 1975, and there's a lot of, folks who've kind of criticized it. It is still used in clinical trials, and it is kind of the gold standard. But for example, in stage 1, you can have one lymph node, and that could be stage 1, but you can have multiple lymph nodes all over, and that can still be stage 1. Obviously, so these patients are heterogeneous, is what I'm trying to say. Stage 2 is stage 0 to 1, but then you can have splenomegaly, hepatomegaly, or both. Stage 3 is stage 0 to 2 with hemoglobin less than 11, so that's basically anemia. And then stage 4 is thrombocytopenia. You can see platelets less than 100. Again, the idea is that as you go kind of higher stage, indicates organomegaly, and later on bone marrow infiltration with anemia and thrombocytopenia. This is from the NCCN guidelines from CLL, the most recent, just showing us some prognostic information. There have been a lot of different, as we understand the biology of CLL, a lot of both molecular as well as chromosomal aberrations that can give us important prognostic information. And I'm going to focus on kind of a few ones that are important. One is deletion 17p. So deletion 17p is really important because it really has an adverse profile, and these patients are actually considered chemorefractory. So they don't respond to traditional chemotherapy agents, and so we are starting our novel agents in these patients. So you can see kind of median survival of 33 months in this patient population. Deletion 11q is also considered an unfavorable cytogenetic abnormality, although it's better than 17p, but still unfavorable. Trisomy 12, or the addition of a chromosome 12, is considered neutral as far as cytogenetics, and then deletion 13q is considered a favorable abnormality. So I would like to kind of point out here, although it might sometimes, it may not make a whole lot of sense, like if you were just thinking about it logically, but if you have no mutation or like normal cytogenetics, or trisomy 12, as you can see, that's considered neutral risk, okay? But if you have the deletion 13q, that's actually considered a favorable risk, and that's just good to know. The other one that's tied into deletion 17 is this TP53 mutation right here. This is considered, if it's mutated, it's considered unfavorable and very similar risk to deletion 17p. So again, you can have deletion 17p, or you can have p53 mutation, and those are considered, unfavorable. As far as the disease progression, so you can see if the patients have indolent disease. So as far as stage 0, for example, these patients can live, a long time, decades, without any treatment, really. But again, need a lot of monitoring. As far as stage 4, you can see median survival is about 3 to 4 years. So that's, the idea is that we really, the magic is, when do we start treatment, and how do we prevent patients from getting, from stage 0 to stage 4. We know that not everybody needs treatment. A lot of people can live their entire lives with CLL and not need treatment, believe it or not. But the science now is trying to identify that magic point at which we would want to start treatment. And then I wouldn't worry too much about this kind of smoldering CLL. This is similar to stage 0, I would say. I will point out here Richter's transformation. This is really important, and you learn in CML, chronic myeloid leukemia, that patients, if untreated, can transform into blast phase, which is basically an acute leukemia. Chronic lymphocytic leukemia, or CLL, as I mentioned earlier, is really should be thought of as a lymphoma because it actually ends up transforming into a diffuse large B-cell lymphoma, which is really an aggressive lymphoma. And these patients are, I mean, has really dismal outcomes, and really median survival is about 5 months. This slide says it occurs in less than 5% of patients, and that's really here in the United States because we do have, a much better healthcare system. But globally, like if you are looking at countries that are low to middle income countries, a lot of patients might even be diagnosed at Richter's. Obviously, if patients are not being monitored, that is the risk is the transformation to diffuse large B-cell lymphoma. As far as response criteria, so this is from the IWCLL guidelines. This is the international working group for CLL, and they really are internationally recognized, and they put out guidelines about every 10 years or so. Their last one was 2008. Now they have one in 2018, providing guidance for what's the definition of complete response, partial response, progressive disease, as well as stable disease. And this is important, not just for clinical trials and being able to speak kind of the same language, but also in clinical practice. And a few things I'll point out. So you can see for complete response, the definition of complete response, you don't want to have any large lymph nodes. That makes sense. Like liver and spleen size should be normal. That makes sense. Constitutional symptoms, so any symptoms patients might have, like fever, weight loss, things like that, should have improved. Circulating lymphocyte count should be normal. Platelet count should be normal. Hemoglobin should be normal. So all of this easily, through physical exam and labs, we can easily detect these. However, it also does require a bone marrow biopsy to make sure that patients don't have any CLL cells. And what I can tell you that in clinical practice, we typically don't do bone marrow biopsy on a regular basis in CLL patients. And the reason for that is because we actually have ways of detecting disease. Remember that the disease typically is in the circulating lymphocytes. So if we're able to detect that the disease is gone in circulation, so lymphocytes are normal. We can even do MRD, so minimal residual disease, and kind of look at the presence of disease at kind of low numbers at these quantitative tests that are highly sensitive. And then we can look at the hemoglobin and the platelets. That tells us if the hemoglobin and the platelets are normal, and they weren't before, that can tell us that this patient is responding. Especially with a lot of our novel agents that are really highly efficacious, a lot of people feel like doing a bone marrow biopsy might be overkill. So oftentimes this is, I'm bringing this up to say a lot of people hesitate to say the word CR to patients because the technical definition requires a bone marrow, but we know, we can deduce that a lot of patients that we treat, if all of these things are normal, and we're doing other tests through peripheral blood that give us the sense that the patient doesn't have any disease presence, that they probably are in a complete remission. And just keep in mind too, a lot of our patients are older too, so subjecting them to a bone marrow biopsy is not, it's not ideal. So as far as this question, so what stage is AD CLL, and when should she start treatment? So if you guys could look at this, you have, so this patient has progressive fatigue, hemoglobin is 10. When should she start? Should she start treatment? The physical exam says no splenomegaly, no hepatomegaly. So I don't know if I'll give you guys maybe a second if you want to pause the video to kind of come up with your answer. So I hope that you guys could see that the hemoglobin is 10. And if you look back at the rise staging, the presence of splenomegaly and hepatomegaly is stage 2. This patient doesn't have any. However, they have something worse. They have a hemoglobin less than 11. So that tells us that this patient is stage 3. So even though they may not have splenomegaly, hepatomegaly, if they have anemia, they're automatically stage 3. Because we know that there is bone marrow infiltration. So I just wanted you guys to get that sense. So, and then the next question, should she start treatment? So we'll talk about that now. So there are a few treatment principles I want you guys to take into consideration as far as treating CLL. So the first one is risk stratification. Basically, patients who are stage 0 to 2 as far as rise stage, you can think about observation versus treatment, and that's really an individual decision that oftentimes occurs between the hematologist and the patient. I've certainly been called to have those conversations, especially for patients who come in on a monthly basis for monitoring. I might, discuss the merits of starting treatment. A lot of times, patients are hesitant to start treatment even when it might be appropriate because they're concerned about toxicities, again, given their age and comorbidities. So oftentimes I could be pulled in to have that conversation with the patient and, take part in some shared decision making. However, to make it clear, high risk patients, so rise stage 3 and 4, like our patient case, should be offered treatment. There's not really a lot of negotiation there. So I think that's really important to keep in mind when we're thinking about CLL. Some patients, will come in, they will have read about CLL, WebMD or whatever they read online will say, patients may or may not receive treatment. But if you're coming to the clinic and you're anemic, there's not, you are going to get treatment, and that's what we're going to strongly encourage. So it's important to have those types of conversations and let the patients understand that once they move to stage 3 and 4, there is a significant kind of that survival. The median survival of untreated CLL at later stages is significantly shorter comparatively to the lower risk patients. The second treatment principle is, when do we treat lower risk patients, so stages 0 to 1? So you can see if they have symptoms, that's one of the biggest indicators. What do I mean by symptoms? So stage 1, for example, is lymphadenopathy, right? So enlarged lymph nodes. If someone has a small 1.5 centimeter lymph node, cervical, doesn't bother them, they could say, hey, I'm just going to wait because this doesn't bother me. If they have a 10 centimeter lymph node in their mediastinum and it's compressing on their lungs and they can't breathe, which is actually a patient case that I've had, that would be a case, that patient is stage 1, but they might be, in the hospital needing, some oxygenation because they can't breathe. And those are patients that really need to start treatment right away. So symptoms, end organ function. So this, especially if they, for example, have hepatomegaly or splenomegaly, and there's, kind of organ damage from the CLL cells that could impact us. Bulky disease, as I mentioned, from the lymphadenopathy. Progressive anemia, progressive thrombocytopenia. So this is like their hemoglobin is not quite 11, but let's say they're a man, they started out at 16. You see them next time they're at 14. You see them next time they're 13, and then they're 12. Their lymphocytes are continuing to climb. You might have a conversation, they're not stage 3, they're like stage 1, but they're progressively, their hemoglobin is getting lower and lower. So that could be a reason to treat even before they get to that technical definition of stage 3. One thing that I did not put on here, though, that I've implied is, again, and I've sort of said a few times, is this idea of like the lymphocyte doubling time, or how quickly the lymphocyte count is increasing, that is really an important marker. And there are technical definitions in the IWCLL guidelines, but just know that if that rate of increase continues to go up, then we will discuss starting treatment with the patient. The next treatment principle is treatment groups. The NCCN guidelines used to have 4 treatment groups in the past, but they've really simplified it to 2 treatment groups now. So even though I mentioned earlier, I talked about 11q, for example, deletion, and there are a lot of other on that NCCN prognostic information page. There are a lot of molecular mutations that have different different prognostic information. However, as far as guiding treatment, 17p deletion has a significant value in terms of helping us guide treatment. So the first question I ask whenever somebody's talking to me about a CLL patient is, are they 17p or not? Because that's really going to impact the way I treat them. And less so now, given a lot of these novel agents and their application in several subtypes of CLL, but still, I do think it's really, really important. When I look at clinical trials for CLL, I look at how many % of those patients had 17p deletion. So the first thing we do is really divide these patients 17p versus not. And then therapy options, just important to kind of think about. We have cytotoxic chemotherapy, which, to be honest with you, is becoming, falling out of favor. And then we have anti-CD20 monoclonal antibodies, which are typically used in combination with cytotoxic chemotherapy, as well as in combination with the small molecules that affect B-cell signaling. So you can see the relevant chemotherapy agents. We have cyclophosphamide and chlorambucil. These are alkylating agents, and then we have antimetabolites like fludarabine, pentostatin, and cladribine. And then we have the monoclonal antibodies here, which are covered with my face, it looks like. I have bendamustine, which is sometimes used as well. Bendamustine has both antimetabolite properties as well as alkylating properties. So you can obviously read about the mechanisms, and I'm sure you've already learned about the mechanisms of actions for these cytotoxic agents. And I'm sure you've learned about the mechanism of action of rituximab as well, but just as a refresher, it does have 3 mechanisms of action. It is an anti-CD20 monoclonal antibody. So the first mechanism is a complement-mediated cytotoxicity. So it binds to the CD20 of the B cell, and then it activates the complement cascade and leads to cell death. The second mechanism is the ADCC, or antibody-dependent cell-mediated cytotoxicity. And here you have the monoclonal antibody that binds to the CD20, and then you have natural killer cells or other kind of cells that can bind through this receptor, and then that leads to the release of these cells that these substances that lead to cell death. So antibody-dependent cell-mediated, here the cell being natural killer cells that carry with them cytotoxic substances. And then the other one is activation of caspases, and which leads to apoptosis. And all of these monoclonal antibodies have some component of these 3 mechanisms, but some have higher ability towards one, ability towards one mechanism versus another. So I'll talk about those now. So one of the newer monoclonal antibodies approved is ofatumumab. I'll tell you that it doesn't really get used very much now. However, it was studied in relapsed CLL. Its sort of unique area was it has a potent complement-mediated cytotoxicity compared to rituximab, and it actually, as you can see here, binds at a different epitope of CD20. So that was sort of what made it unique. And it did have activity in patients who had failed rituximab in the past. So from that perspective, it's superior, or has kind of benefit there. However, it was studied in the relapse setting in a phase 3 trial, comparing it to Ibrutinib, which I'll talk about next, and it did really had poor survival benefit compared to Ibrutinib. So really, its role now is very much limited to other types of lymphomas. Obinutuzumab, however, is an even newer monoclonal antibody that's humanized. You can see here that it has indirect cell death compared to rituximab. It has enhanced ADCC, antibody-dependent cell-mediated cytotoxicity, and lower complement-mediated cytotoxicity. So that makes it different also from ofatumumab. And it does have a much better efficacy. It's been compared to rituximab head-to-head in the frontline setting. Interestingly, obinutuzumab, a lot of people don't realize obinutuzumab is really it should be used more in the frontline setting. A lot of people think that it has data in relapse setting because they get it confused with ofatumumab. But it does not really have a lot of data in the second line setting. It really should be used in the frontline setting. So that's something that I just want to highlight, that it is effective, but it's only been studied in the frontline setting. We don't really know how it would compare in the relapse setting to ofatumumab or other small molecules. Speaking of the small molecules, there are small molecules that affect B cell signaling, so they work intracellularly. These are small molecules. They're given orally. Drugs like Ibrutinib that inhibits BTK, or Bruton's tyrosine kinase, and then you have Idelalisib here, which is a PI3 kinase inhibitor. Again, the idea is that by blocking these pathways, that leads to kind of arrest of B cell proliferation and malignant B cell initiation and progression. BCL2, so I talked about the importance of BCL2, the role of BCL2 in CLL pathogenesis. So again, BCL2 is very, very important and tied to apoptosis, and we do now have a BCL2 inhibitor. This is just very simple cartoon, shows that CLL cells are addicted to high levels of BCL2, and that essentially what BCL2 does is it makes it resistant to anti-cancer treatment, as well as these cells that have high expression of BCL2 are also resistant to apoptotic signals, and so these cells, they live for a long time, and they are not really responsive to chemotherapy. So Venetoclax inhibits BCL2, and that leads to response to anti-cancer treatments, as well as it's the body's own biological apoptotic mechanisms, which leads to cell death. As far as our next treatment principle, just to point out, is how we build a treatment regimen. So I might need to retire this slide, because this used to be a cool slide, back in 2014. But now we have all these new agents. So, but back when chemoimmunotherapy was what we used all the time, I would make the point that we take one, antimetabolite, and then we take one, CD20, and then an alkylating agent, again, trying to use different mechanisms of action. And then this regimen, for example, FCR, is really, for a long time, for over a decade, was the frontline treatment option for CLL. And as we'll discuss soon, that is really no longer becoming the case. Here, again, I mentioned here, so cytotoxic drugs only used in a very small subset of good risk patients and young patients. These next few slides, just, again, because these cytotoxic agents are not used very much, I have these slides for you more as a reference to show you the progression of how we used to use just like fludarabine by itself, then with rituximab, then cyclophosphamide, and then FCR versus FC showed that FCR was better. Just showing you some of the data to justify why we use FCR for a long time as a line agent. And then alternative purine backbones like pentostatin and bendamustine have also been evaluated. As far as newer agents, we have a study that looked at obinutuzumab and chlorambucil. Obinutuzumab was studied in the frontline setting in older patients and shown to be very much promising. Ibrutinib was studied in the relapsed refractory patient population first, then moved up to frontline data, and again showed to be very much highly effective. And we'll talk more about this toxicities in just a little bit. And idelalisib also has data in relapsed refractory patients who are older and comorbidities. So back to our patient. So she's 78, has hypertension, osteoporosis, progressive fatigue. So what should AD receive for frontline treatment? Cytogenetic studies are normal, and she does not have any 17p deletion. So if you guys remember the other slides, I believe said that she has 11q deletion. Let's see. So this is straight from the NCCN guidelines. As far as first line options in patients without any 17p deletion. So if you guys remember, we separate out our patients into two buckets. Either they don't have 17p deletion or they do. And even the guidelines are separated in that way. So you can see here suggested treatments for CLL without deletion 17. So you can see here preferred regimens. The category 1 recommendation is really, especially in patients who are older, older than 65, or younger patients with comorbidities, is Ibrutinib. And there is data in that patient population to justify the use of Ibrutinib in the frontline setting. Acalabrutinib plus obinutuzumab has also been studied. We do need more longer-term data. Acalabrutinib is really another BTK inhibitor. I'll talk about its role in just a minute. But it does. I wouldn't say right now that it should be used over Ibrutinib because we just don't have that data. Although if you ask the makers of Ibrutinib, AstraZeneca, they'll tell you because of its specificity to BTK, and it has potentially less side effects. So we'll touch on that in just a bit. In a minute. Venetoclax and obinutuzumab is another regimen that has been studied, and its appeal is that whereas Ibrutinib is studied to be given daily for indefinitely, Venetoclax and obinutuzumab is really given for 12 months, and that's really an attractive option. As we'll talk about, Venetoclax was initially approved in the relapsed refractory setting in patients who had failed Ibrutinib. And so, some people feel like it's kind of the big gun. And so giving that first could lead to potentially, problems down the line if patients end up relapsing from Venetoclax. So in terms of sequencing, we still really are unsure. However, I can tell you at UNC hospitals, we do use quite a bit of Venetoclax obinutuzumab in the frontline setting. In younger patients, Ibrutinib again has data in that population. It's being used. So it's basically similar drugs. You can see very similar drugs there. Really, the difference is in the other regimens. So these regimens in the older patient populations tend to be much more gentler than for younger patients. That FCR regimen I told you, which really does have a lot of toxicities. Is available here if for some reason patients can't receive any of these other preferred regimens. As far as if patients have deletion 17p first line options, you can see preferred regimens. You can see again the same drugs, pretty much acalabrutinib, ibrutinib, venetoclax, obinutuzumab. You can see, as I just want to point out, the other recommended regimens, you don't really see any of the cytotoxic agents. You don't see fludarabine, you don't see cyclophosphamide. Those drugs, remember, they do not work. They're not an option. They're not an option for deletion 17p patients. Okay, so just making that point. Again, most people would argue using either Ibrutinib or Venetoclax, just because Acalabrutinib is newer and we're still waiting for kind of more longer data. Um, so, um, so let's say you decided to go with Ibrutinib. So AD's hematologist started on Ibrutinib because he declined any IV chemo. And that would mean that is another important thing to note is Ibrutinib is all oral. Venetoclax and obinutuzumab, which is an option for older patients. The obinutuzumab is an IV chemotherapy drug, and it does require you can get a lot of infusion reactions from obinutuzumab. So some patients, when they hear that, they really don't want that. Anyway, so the patient notifies you about an upcoming cataract surgery, and why is that relevant? We'll talk about it in just a second. Um, so Ibrutinib, one of the most important side effects to keep in mind is that it has antiplatelet effects. Okay, so this is really important as far as the role of the pharmacist in kind of alerting, especially the hemon pharmacist, alerting not just the patient, because the patient will know, and obviously the hematologist. So if you work in a cancer hospital with hematologists, they're going to know about Ibrutinib. But the people that are not going to know are those in primary care, the people the patients, maybe community pharmacy. They're not going to know the patients, like here, and the ophthalmologist is not going to know. As far as for cataract surgery, the surgeon's not going to know. All of these different specialties, people know about aspirin, for example. They know about warfarin. They know about, they're learning about DOACs, and they will ask the patients, are you on aspirin? You're going to have surgery. We need to stop the aspirin. We need to stop the warfarin, so on and so forth. They're not going to know to ask about Ibrutinib. So that's why it's really important when we're educating the patient to say, if the patient has upcoming surgery, we need to work with that um, healthcare provider to see, to determine what the risk of bleeding is, and then, appropriately, potentially, you need to recommend holding the Ibrutinib if necessary. So if a patient is going to have a, mild to moderate bleeding risk procedure, Ibrutinib needs to be held 3 days before the procedure and then 3 days after the patient completes that procedure. Um, and then if it's high risk, then it's 7 days before and 7 days after. One thing I always tell folks is that, like, the after is more it's more variable. Obviously, it depends on the healing process. So if someone has delayed wound healing for some reason, that obviously could mean the patients may need to not be on the drug for even longer than 3 days. As far as other toxicities of Ibrutinib, you can see that hypertension can be seen in up to 71% of patients with CLL and who are on Ibrutinib. And the initial package insert actually had rates of hypertension that were, I think, 14%. But over time, as patients are on these therapies, side effects can continue to emerge. And 71% is obviously very much alarming. That was what was seen in a recent review article that was published, and so that does require close monitoring. These patients you may be called as a pharmacist to help recommend an antihypertensive, and keeping in mind that there are some drug interactions, especially with the calcium channel blockers. Atrial fibrillation can be seen in 6 to 9% of patients. So just making sure to review medical history of the patient before starting treatment. It's not a contraindication if it's controlled. And but the one big thing is that, given the fact that Ibrutinib can cause bleeding, if patients are on aspirin or other, DOACs and things like that for anticoagulation, that is a problem from a bleeding perspective. And one thing I always tell my providers is that Ibrutinib can cause it does have antiplatelet properties, but that does not mean that it's protective from cardiac health perspective. So that we don't have that data to say that you can just replace aspirin with Ibrutinib and you're fine from an AFib antiplatelet perspective. So that's where, like, you really need to work closely with your cardio-oncology colleagues to help manage the patient. Um, so as far as GI toxicities, you can have some nausea. It's really very mild. The diarrhea is also mild, and usually lasts for the first honestly week to 10 days. That's why oftentimes when patients start on ibrutinib, I like to see them in about within 2 weeks to just check in on them and see how they're doing again, and just try to coach them through it and encourage them and let them know that they can get through it. And most people do just fine. GERD can be an issue. I oftentimes will have to start an H2RA, or we can get away with Tums. That's obviously great, but most of the time people might require daily treatment. Bleeding, again, we talked about this consideration for surgery in our older patients. I often if they have caregivers, I let them know about the fall risk, and preventing falls becomes really critical. And then as far as infection risk, really important to note that a lot of people know about ibrutinib's effect on platelets, but they don't realize that it also has effects on neutrophils specifically, and so it can impair neutrophil migration, the phagocytic function of neutrophils. So you can definitely have chronic infections, even though obviously the disease itself, due to the B cell's ability to impaired ability to produce antibodies, you can have infections, but even due to the treatment, due to ibrutinib, you can see normal levels of neutrophils, but the neutrophils themselves are not functioning well, so you can have chronic infections. I'll also note that the same thing with the platelets. You're not getting thrombocytopenia, okay? You have normal platelets, but the platelets are not functioning as well. So similarly with what you see with aspirin, you don't see thrombocytopenia, but you see increased risk of bleeding because of platelet function being impaired. One thing I didn't add on here, it is sometimes marked as a toxicity, but it's not really a toxicity. I had it in the previous slide, is you can have lymphocytosis, and so when you start treatment, 2 weeks after starting treatment, you actually see an increase in the number of lymphocytes, and then that can last up to 8 weeks on average, and then it can start to drop at around 2 months. Here I have like the role of acalabrutinib and ibrutinib intolerant patients. We recently did a multi-center evaluation of acalabrutinib use, and again, acalabrutinib just got FDA approved for CLL recently, and people all around the country were using it off-label, and the main reason why patients or providers use it is really in patients who may be intolerant to ibrutinib, and that's really the way people think about it right now. We do need a little bit more mature data. Ibrutinib has been around since 2013, so people just feel a lot more comfortable with it. Acalabrutinib is potentially, it could be a good option, and may eventually become the preferred BTK inhibitor, but we're just not there yet. So one thing I'll note, and I'll come back to that point, and it's related to this actually, the importance of adherence is taking ibrutinib every day is so critical. This was a study that was done looking at one of the clinical trials. It was a retrospective analysis of one of the clinical trials, and what it showed, as you can see, is so basically this line is patients who were greater than the percent mean dose intensity, and that was around 95%. And in the red here is the less than the average mean dose intensity. And what you see is that patients who were less than 95%, which was the mean dose intensity, as far as their adherence, that impacted their progression-free survival. So progression was tied in to adherence, and overall survival. There was also a trend in overall survival, and you can see the p-value that is statistically significant. So the take-home point is that 95% means literally like taking the drug every day. It's so critical. And yes, I mean, sometimes because patients have surgeries, we may need to hold the drug, and we know that that happens. But if patients are holding it for like 7 days over a period of 10 years, that's really, that's still, they can still be over 95%. That's not a problem. However, missing a dose here, a dose there, like 1 or 2 doses every month, that really is problematic, and that will get patients to not get the benefit from the drug. All right. One thing I was going to say, I thought I had an acalabrutinib slide, but basically, acalabrutinib is dosed twice a day. And so that is one thing to keep in mind. It's dosed twice a day, so that could potentially compromise adherence. So just keep that in mind. All right. So 1 year after initial therapy, AD relapsed and was found that she had a p53 mutation, and she has a 17p deletion. So what would we want to treat her with now? All right, so when we're talking about relapsed and refractory disease in patients who have no 17p deletion, and one point I'm trying to make with this patient case is to tell you we have to do that FISH every time when we are considering changing therapy, because the disease can evolve. So you can have newly diagnosed disease that's 17p like wild type, and then they can progress, and then now they can pick up that mutation. So that's really important to realize. So the relapse refractory setting, so you can see acalabrutinib and ibrutinib both have good data. Ibrutinib is older, presumably, the acalabrutinib data, I'll tell you, is not in patients who failed ibrutinib. So in this case, even though the patient has failed ibrutinib, and even though acalabrutinib is like a preferred regimen, if you go back and look at the clinical trial, a lot of the patients did not have ibrutinib in the past. So, and it's the same class, it's a BTK inhibitor. So I wouldn't feel comfortable giving someone who has failed ibrutinib acalabrutinib. So Venetoclax, this is really the role for Venetoclax in my opinion. Venetoclax rituximab has data, in patients who have failed ibrutinib, and can be really helpful, and can be utilized there. The only thing I'll note is that uh, actually, yeah. So you can see, I thought that they didn't have it here in the younger. Even though the median age for the study that evaluated venetoclax rituximab, the Murano trial, was older, it is still recommended, and even in the younger patient population. That was the thing that I was looking for here. So it is still a category 1 in the younger patient population, because that study, they did include some younger patients. So venetoclax rituximab really would be probably the more preferred therapy. I will say, let's say your patient received chemoimmunotherapy in the past, like FCR, and then now is coming back, and now is relapsing. You could consider acalabrutinib. If they're BTK inhibitor naive, then you can consider acalabrutinib. That would not be the case in our patient, so that would not be an appropriate recommendation. Relapse refractory therapy in patients who have 17p deletion. Again, acalabrutinib if they're BTK inhibitor naive, ibrutinib if they're BTK inhibitor naive, but most patients in the US, would have had those drugs, so venetoclax or tux again would be appropriate for the patients. So just to tell you guys a little bit about venetoclax, again, it's a BCL-2 inhibitor. One thing to note is in the initial phase 1 studies, the dose-limiting toxicity was tumor lysis syndrome, including 1 death. And this is because the drug is, highly active, and you have all these circulating lymphocytes, and so you have cytotoxicity that results, and the contents of those cells. That's what tumor lysis syndrome is. You guys may have learned it. So you have rapid hyperkalemia, hyperphosphatemia, hyperuricemia, hypocalcemia, which eventually leads to organ damage, mainly nephrotoxicity, and that led to a death. And so basically, um, the company AbbVie Pharmaceuticals actually changed the way the drug is dosed. So even though the full dose is 400 milligrams daily, um, it is now given in a ramp-up fashion. So you can see week 1 is 20 milligrams daily, week 2 is 50 milligrams daily, week 3 is 100 milligrams daily, week 4 is 200 milligrams daily, weeks 5 and beyond are 400 milligrams daily. And you can see that there is this actual ramp-up pack that comes that are color-coded. So I think that the company has actually done an excellent job for CLL patients as far as managing the ramp-up process. I can tell you from a pharmacy management perspective, this process is led by the pharmacy team. These patients, when they get started, they get their initial education by the pharmacist, and then they get seen every week prior to each dose ramp up. Their labs get monitored. Any issues there are, the pharmacist manages and involves the physician when necessary. A little bit more detail as far as, again, this is all from the manufacturer. You can go to the company's website and find it. There is a risk stratification process for tumor lysis. So what you do is first you assess their risk for tumor lysis as low, medium, or high. So, as far as like low risk would be if all of their lymph nodes are less than 5 centimeters and their absolute lymphocyte count is less than 25. That would be low. Both of those have to be met. For high, it would be any lymph node greater than 10 centimeter, automatically high, or lymph nodes greater than 5 and ALC greater than 25. And then, so you can see that medium is sort of that in-between spot. And then as far as prophylaxis strategies, if they're low, you can, mainly do oral hydration. These patients are ramped up every week at the outpatient setting. They are all given allopurinol as far as to prevent hyperuricemia. If they are high, they get oral and IV hydration, and really these patients should be admitted to the hospital. So you can see there's inpatient monitoring, especially during the first 2 weeks when they start the 20 milligram dose and the 50 milligram dose. Again, you can see that there's a lot of coordination and monitoring that's required by the pharmacist there. And again, medium is sort of that in between. Nobody likes the medium patients because it says consider additional IV and then additional IV hydration. Consider inpatient for these patients who may have like pre-existing renal disease. So, even though this is laid out, and I think this is a really good guidance, a lot of times we are discussing each patient. There may be some patients who, they might be technically a medium, but we might say, we don't really, this patient's, 80, we may not feel comfortable with them doing any of this in outpatients. We might bump them up to high risk. Some patients who might be low, we might bump them up to medium if we feel like, they need extra monitoring. I cannot emphasize the importance of drug interactions, and a lot of times when people ask about, the role of the pharmacist in this setting, can't a nurse practitioner or physician assistant just monitor these patients? And I say they can, but the biggest thing I'm concerned about is the drug interaction. As far as why, I think it has to be a pharmacist who needs to be involved in the care, because both Ibrutinib and Venetoclax are CYP3A4 substrates, and so you can see this is just straight from the package insert. For Ibrutinib, the effects, and then there's even you can see dosing recommendations for both moderate and strong CYP3A4 inhibitors. There is also guidance for inducers. This is for Venetoclax. One thing I'll note is that Venetoclax is approved for CLL and AML, acute myeloid leukemia, and so it's really important that the drug interaction recommendations differ based on the indication. So when you're looking at the package insert, that's really important to keep in mind. Especially, you can see during the ramp-up phase for CLL, you really cannot use any strong CYP3A4 inhibitors. And if the patient is on a strong CYP3A4 inhibitor and you cannot take them off, you just can't use Venetoclax because of the risk of tumor lysis. It's just not a risk. I've been asked before, and I've told my providers it's just not a risk. We saw deaths in the clinical trials that we just cannot take that type of a risk. Last slide. I didn't talk much about the PI3 kinase inhibitors. There are two of them. There's idelalisib and duvelisib. Um, uh, and basically, what happened is idelalisib was seen to be effective, and it does have a lot more toxicities compared to the other novel agents, mainly immune-related toxicities. Um, However, so it was studied in older patients with multiple comorbidities in the relapse setting, had some decent efficacy, but still not as good as when compared to like Ibrutinib or Venetoclax. However, then the company studied the drug in the frontline setting, and actually patients in the idelalisib arm experienced more deaths. So all of a sudden, unfortunately for the company Gilead, this drug is now associated with death. It's not good when your drug is referred to as the death drug, which really that's what a lot of our docs refer to it as. I will say there are some patients who come to me from outside hematologists like treated locally who may be on idelalisib. So it is important to know and understand the drug and its mechanism. And there are PI3 kinases that are being evaluated. For example, duvelisib recently got FDA approved, and duvelisib actually, um, you know, um, potentially could be tried in patients who may have failed ibrutinib and venetoclax. And if you're really wanting a different mechanism, trying to avoid chemoimmunotherapy, you could try it. But I'll tell you that it doesn't, like, as far as sequencing, um, you know, we know that PI3 kinase inhibitors, post BTK inhibitors, and BCL-2 inhibitors, they really don't work that well. But people still, that mechanism is still interesting, and we have a lot of in vitro data to make us um, uh, um, understand that mechanism is still something that is being explored, and there are several other drugs that are being evaluated that to make the drugs more efficacious and safer. And so hopefully one day they can be included in our treatment armamentarium. So that is all I have. Again, I don't have my email address on here, but it should be on the syllabus. Yeah, so feel free to contact me if you guys have any questions. And it was, it's a little weird to do this in my office, but I hope you guys learned something about CLL.